being conscious of time, I kind of went long, which isn't uncommon.
It's easy.
I have so much to say. It's so little time.
I realize this isn't like a mic.
Yeah.
Okay.
Yeah.
Alrighty. Is everyone pretty much back? We can get started. Well, I am very happy to be here, so thank you for inviting me. And I am Jandra Mueller. I'm a pelvic floor physical therapist. I also have my master's in integrative health and nutrition, as well as I'm a ISWISH fellow, and I'll talk a little bit about ISWISH at the end, but I encourage, if you have not heard of ISWISH, or the International Society for the Study of Women's Sexual Health, it is a wonderful society, multidisciplinary, a lot of mental health, physician, PT, I mean, everyone across board, researchers, pain management doctors. It's a lovely community, all focused around improving women's sexual health, which includes pelvic pain and everything that goes with that. So I'm their current co-education chair, to be education chair for the next couple of years coming up. But if you haven't heard of it, I encourage you to look into it. And our upcoming annual conference is in Long Beach this coming February 2026. It's a great resource community. So thank you for having me. And we're going to talk about that biopsychosocial model perspective on pelvic pain and sexual dysfunction, including pelvic floor PT. But as you'll learn throughout this, it's so much more than the musculoskeletal structures that I kind of encounter on a day-to-day basis, and how I got started in doing that. And I would say probably the conversations I have with most of my patients daily reach well beyond physical therapy specific tasks, because what I can do is impacted by so many other factors that need to be addressed, or collaboration with other providers, like Tracy, naturopaths, integrative docs, OBs, pain management specialists. And when I started into pelvic floor physical therapy, a few years in, I started seeing more patients with pain. And I noticed that, I think there's some things that I don't know here. Our initial training was more on, how to do a pelvic floor exam, find the muscles, how they contract, how they relax, some tools you can use to help facilitate contractions or relaxation, like for incontinence, prolapse. But really there was not much, at least introductory, into pain. And when you get into pain, there's really nothing about hormones. And when you're working with a group of muscles that are surrounded by tissues that need hormones, that becomes a really big issue, and you don't really see the progress you're expected to see by just addressing the muscles. Sometimes you can actually make it worse. So I just knew I didn't know what I didn't know. I didn't know what I didn't know, but I knew I didn't know something or many things. And so when I moved back from Hawaii to California, I started with the company I was previously at for almost 10 years, the Pelvic Health and Rehab Center, and got introduced to ISWISH, and my mind was just blown. Like, all the answers that I needed were found just constantly coming in. And I had to take myself out of the PT world and start going to medical conferences to really understand how I can actually do my job better. So that's where ISWISH kind of came into my life in 2016, and it's been amazing, and I couldn't do it without having that knowledge. So I'm happy to share with you all some of the things I've learned. So we'll start with talking about that biopsychosocial impact of pelvic health and just our roles within treating this population, or women in general, throughout the lifespan. We'll talk about what the pelvic floor is, what the anatomy looks like, how it's supposed to work, what it does, aspects of pelvic health conditions throughout the lifespan. Women are hit with so many opportunities to have pelvic floor dysfunction, men as well, but women, there's so many factors that put us at risk for having dysfunction in our pelvic floor. We'll talk about what pelvic floor physical therapy is, what that looks like, what we can do, and then take a little bit deeper dive into some of the history and pain dismissal with some of the common things that I think both of us will see, both in PT and you all as primarily mental health providers. So the problems. Symptoms of pelvic floor dysfunction often come under medical diagnoses like interstitial cystitis. You think bladder. Well, now it's really just transformed into a name for certain symptoms, still often given not appropriately, but what people don't realize is a large majority of people with IC have pelvic floor dysfunction, and now there's 9 subtypes we recognize in the US, one of them being pelvic floor dysfunction. Well, if one of the 9 subtypes of a bladder issue is pelvic floor dysfunction, isn't that just pelvic floor dysfunction? So we work under more of an impairment-based model, so altered motor control, difficulty, or like poor strength or low endurance, things like that that help give a reason as to why they're having a symptom. So it confuses people, and then people think, well, why do I need pelvic floor PT? How is that going to help me? There is significant barriers. The biggest one probably being the knowledge gap, and Tracy hit on this with the research and what we know about women versus men. They're different. And as they present with certain things, most of the research has been done on men, and that's just not true of all women or most women. We are not just little men, and so things get missed and cannot, it's a reasonable outcome to dismiss somebody from the emergency department with anxiety, and it might be a heart attack, because that is how it presents more in women versus men. We don't have those similarities. Even lab values can be different. So we need better research. We need more of it, but aside from research, just what we get in our kind of entry level and even further education, we have to kind of go pretty deep. And like I mentioned, I had to go outside of my own profession to really understand how I can actually do my job. And a lot of people don't realize that, because once you're out of school, you go through your, Con Ed, and there's a lot of variety, but you still may not be hitting all the aspects and have to reach out further, which comes to the additional training. I think all of us that are here, right, this is additional training. So we spend our time, we spend our money to go to different things to better help our patients. And there was no pelvic floor training in my entry-level PT program. So I graduated, I'm allowed, after I passed my exam and get licensed, to treat anything and everyone, but we never even learned about pelvic floor PT. And that's still like that for most cases, most schools. I took a pelvic floor physical therapy level 1 course while I was still in PT school, which was quite humbling and very, it was like big room with 300 people, and shortly, into it, you're getting on the table with 4 other people, everybody, sticking gloved fingers in your vagina, assessing your muscles. So as a student with all these professionals, it's very intimidating. Access, we know, is also an issue. Financially is probably a huge one, especially because a lot of us are out-of-network providers and don't take insurance. And it's really amazing when you find that special unicorn person who does, and they are an expert, and you never want them to leave where you live, so you can keep sending your patients to them. But there are limited experts, even that are out-of-network, and there's many more patients than there are providers to treat these issues. There's also for PT, and probably similar for you all, there's no standardization of care. So if a patient comes to you or to their physician and you all now are like, hey, have you gone to PT? And they're like, yeah, I've seen 3 pelvic floor PTs. You kind of think almost cross that off the list, but in your mind, it should be like, let me ask you a bunch more questions about how that went. What did it look like? There's pelvic PTs that never even have done a pelvic floor exam. And while you can definitely make changes and get your outcomes, at least for the most part, in a lot of cases, without doing that, you are missing a huge piece if you are seeing a pelvic floor PT and you are not, have never undergone any sort of internal examination to actually look at your muscles. People don't know those muscles are there, and even when I'm evaluating somebody's ab strength and I look to see their motor control, half the time, once I do their pelvic exam, what I think is happening is definitely not what's happening. And so you don't know that unless you look. I'll also show some pictures later on of a few conditions, and I think it'll be eye-opening because I do get to see some of that, but you all, likely will never be able to say, hey, let's, look at your tissues down there, right? That's not really in your scope of practice. They're probably like, hey, something I don't know about this person. That's not what you do, right? But if you can understand what might be going on, you can ask the questions and send to other providers who are able to do that exam. And then they can get back to you and say, you were right. I think that is what was going on. So there's no standardization of care. So don't assume that they've done everything with their pelvic PT just because they've gone. So looking at this, my role really kind of emphasizes the biological piece of it. I'm looking at neuromuscular structures, though it definitely gets into the other realms of how their symptoms are impacting them. I think with the psychological piece, I can help kind of screen, and then thank God I have all of you all, because we couldn't do this without our mental health counterparts or our physicians. And it really takes a team to help patients get and feel better, right? And I think both of our roles really impact their social aspects of their life. Kind of the help they need and help case manage, like Tracy had mentioned. Whereas their physician, they may be a tool to get XYZ, do a procedure, surgery, but they don't really have time to handhold and walk the patient through all they need to do. And so we can be a good team player in that regard because of our unique opportunity with the time spent with our patients. So pelvic floor anatomy, function, and dysfunction. So this is sort of a 3D model of the pelvis with the pelvic floor muscles kind of separated into the different layers. There are 3 layers of muscles. For the most part, we talk about a superficial layer, which is these first 2 layers, and then this deep layer of muscles. But the pelvic floor overall is a group of this musculofascial structure. So it's not just muscles. There's a lot of fascia that plays a role in our structural integration. And then these are just the internal muscles. The pelvis has all of these external muscles, or the pelvic girdle muscles, that influence and work together with the pelvic floor muscles directly. The primary functions are to support the pelvic and abdominal viscera. They contribute to bowel, bladder, and sexual functioning, as well as pressure management, core stability. They are innervated by the pudendal nerve, which is sacral nerve roots 2 through 4. And does anyone know what pudendal comes from? The word pudendal? It stems from the word the shamefuls. The shameful. So we are the shameful. So we are literally set up to say, this is a shamed area. And so, and that is not just women. I mean, men have a pudendal nerve too. Everyone has two. So, I mean, just knowing that little bit, of course, we don't talk about it. We don't know it's there. How are pelvic health conditions diagnosed? So primarily history and subjective symptoms. I spend sometimes the entire first visit talking to patients to really understand what they're going through, where their diagnoses have come from. And just from listening and hearing certain key things, with endo specifically, I have never sent a patient for an endo diagnosis, surgery. I have not been wrong once in almost 14 years. Not one time. Now, that being said, not every patient got the outcome. That's been disappointing. There are patients where we go through and it's like, damn, that wasn't the main source. Let's keep going. But for the most part, it is a significant part of their pain. Pelvic floor is along for the ride. Sometimes it's the major driver of symptoms along with endo. We'll talk about that a little bit later too, but you can pick this out when you understand these things. You probably already do with many things. We palpate the pelvic floor muscles. So this can be done via a transvaginal or transrectal exam. I can pick somebody from the street and do a pelvic floor exam on them, and I'll probably have findings. So you really have to relate, what are your symptoms, what are you dealing with, to the findings that you find in your exam, and that's how you assess. If somebody could not squeeze my finger super tight, does that mean they have incontinence? No. But might be good to say, hey, I'm noticing at baseline there's some issues here. That may mean that later on in life they may have something happen, or if there's another stressor to their body or injury, they may now develop it. A lot of people ask, how did I get here? How did this start? When there's no major one mechanism of injury, and it's a lot of overuse, kind of little things that got them to a place where maybe then there was an event that triggered this dysfunction and these symptoms. But likely it's been in development for a very long time. Our posture, our repetitive activities, all of that can influence how our muscles show up and work for us. What is important about this last point here is on palpation, if I ask, you're going to feel pressure, I'm touching your muscles, so that pressure is normal, but if it's uncomfortable or you are sensing discomfort or pain, like that is never normal, though it's pretty common. And so there was a study that looked at greater than a 3 out of 10 on palpation for any individual with or without the complaint of pain was significant and is not considered normal. This can be due to muscle trigger points, in general inflammation, muscles overworking. Think about when you that really feels good and it hurts so good on your neck, right? You may not walk around with daily neck pain, but when you touch it, it might be sore, painful. Occasionally you get headaches. Similar, the pelvic floor muscles are similar. So if you're having urinary incontinence or urinary urgency, you may not be thinking pain, but on palpation, if the pelvic floor muscles are involved, that will probably be uncomfortable. And you never realize I didn't even know that was painful. I've never have pain there, but it's because those muscles are working on overdrive. The lactic acid is building up. And so you're maybe getting these hyper irritable spots or trigger points in those muscles that then I or you, if you did it to yourself or your patient did it to themselves, they'd be able to feel some dysfunction there, pain, discomfort. In research, you'll see people use more objective measurements. Of course, my palpation skills are going to be different than somebody just taking a pelvic floor course, though they actually do correlate pretty well. So we use this more clinically, and it is pretty correlated to what we find on EMG and using what's called a dynamometer, looking at pressure and strength and all of that. And so you might see in fancy clinics or research that there's elevated EMG activity or reduced EMG activity. That's actually important because as we talk about what high tone pelvic floor disorders are, I technically can't say high tone because I'm not measuring the tone of the muscle. They can have shortening of a muscle or tightness without having high activity of the muscle. So it's a nuanced term, but doesn't mean that their muscles are constantly guarding and actually active, but over time they might be shortened or tight. So we can start black and white, which nothing, of course, is black and white, but low tone disorders versus high tone disorders are going to be categorized in a way. So we think about our incontinence issues, both urinary and fecal, as a low tone or weakness issue. Pelvic organ prolapse. Oh, you've had 3 kids, you're older, you've gone through menopause, those tissues are just weak and lax. That's maybe not the case. Orgasm difficulties also, and I put the asterisk here because in our research, when we learn about, what can we do to improve our orgasms, or social media posts, get better orgasms, 10 ways, blah, blah, blah. Usually you see something in there about a Kegel, right? Do Kegels. That could actually make your orgasm problem much, much worse because muscles like to function at mid-range. So a muscle at its baseline is going to work best at mid-range. You have the contraction happen and it pulls the muscle tighter to gain a contraction. You also don't work well, your muscles don't work well if they're all the way lengthened. It's hard to create those connections and pull together. This was the whole reason why we don't do static stretching before athletic events. People realize the power outlet is much less when we do static stretching. So now we do dynamic warm-ups. Same concept. So muscles like to work best at their mid-range. I use the example, imagine if you just walked around with a barbell all day. That barbell isn't so heavy, but after 8 hours and then you go to do arms at the gym, you might really feel fatigued, right? So if your pelvic floor muscles are like this all day long and then you try to hold in your urine because you sneezed and that's a lot of pressure downwards, you might not be able to and have leakage. So that's not a low toner or lax issue. It might be a weakness, but the weakness is due to tightness or elevated activity. High tone disorders often come in the form of those medical diagnoses. So dyspareunia, painful sex; dysuria, painful urination; dysmenorrhea, painful periods; proctalgia fugae, or rectal pain; chronic pelvic pain; vaginismus. But all of these may be their own diagnosis with a medical condition, but they also could just be pelvic floor dysfunction or chronic tightness. And so this is where it gets confusing when you're like, why are my painful periods? What do they have to do with my pelvic floor muscles? Well, over time, if you're, month after month in this shortened position, you have nerves that then innervate all the tissues around, and now you develop more sensitivity in the surrounding tissues. And now that made that pain worse. When I was younger, I had cramps. They were just normal. I missed school. Yeah, that's what it was. But then as I got older, I can't tolerate this anymore. The condition may have worsened, sure, but they also might be adding on more of those muscular factors to their pain, and that's further creating more pain generators in the body. So the reality is most of them have a mixed presentation, and that's why you really have to do a pelvic floor exam to better understand what role is the neuromuscular system playing in this condition, but also it directs the treatment. So when people say, are there any exercises you can just give me? That yes, there's lots, but which ones do you need? If I saw somebody with incontinence, who wouldn't think, yeah, you should do some strengthening exercises or Kegels? So that makes sense, right? But it actually may require them to learn how to relax their muscles before they can contract them. Or instead of doing 10 pelvic floor contractions in a row, and by the 6th one, they're only using their glutes and they're actually pushing out and doing exactly what we don't want them to do, we might need to spend some time for them to be aware of, okay, I can contract my muscle, but now I have to actually take a few breaths to really relax them back and then do it again. So it's much more nuanced than just do Kegels. Symptoms of pelvic floor dysfunction, just breaking it up in a little bit of a different way, you might see in the urinary system urgency, frequency, hesitancy, painful urination. Maybe there's intermittent or constant urethral or bladder pressure or pain. And what Tracy was mentioning earlier is interstitial cystitis at its core is a issue with the bladder lining having Hunner's lesions, or these kind of lesions that are open up and can create pain. The vestibule in the vulva is the tissue inside of the labia minora, but surrounding the urethra, the vagina, and that tissue is highly innervated and needs estrogen and testosterone, which is complicated by many things, which we'll get into a little bit too, but that tissue embryologically is different than the tissue 2 millimeters away on the labia. Embryologically, it develops and it's part of that genitourinary system, and so there's high connection in the brain as to the bladder tissue. It's bladder-derived tissue. So while the tissue might be provoked in the vestibule, the experience to the patient is that it feels like bladder pain. But actually, when you ask, and you ask them to point to where they feel their bladder pain, many people point here. Where's your bladder? Here, right? It's very distinctive. People with true bladder pain will say, I feel it here, but actually sometimes I also feel it here. So those are two different things, and that cues you in. That is something that you all can do. Can you point to on your body where exactly you feel that urgency or discomfort when you have to pee? See if you see people with bladder issues, try it. And many times they will point there, but their bladder isn't there. Stress, urge, or mixed incontinence. So the latchkey incontinence, you're putting the keys in the door and needing to oh my God, I have to go to the bathroom right now, or I'm going to pee my pants. That is slightly different than a strength issue. It's more of a there's more behavioral components to that can be helped. Or deviated urine stream. Muscles are tight on one side, it might, make their urine go one way or the other. Bowel Difficulty of not evaluating stool, sorry, typo, evacuating stool. This is only if the stool is already in the rectum. If the stool has not gone to the rectum, they still may be constipated, but it's not so much a pelvic floor issue as a motility issue or endo, IBS, all of those other things that can cause that. Anorectal pain, chronic fissures, hemorrhoids, pressure management, that can be, pelvic floor muscles can play a huge role. Fecal incontinence, which we've talked about. Sexual symptoms can be absent or diminished orgasm, pain during arousal or orgasm, clitoral pain, both the dyspareunia, so superficial or entry dyspareunia, and that might not just be, penis and vagina sex, it might be toys, dilators, pelvic tools, tampons, fingers, speculums. Postcoital pain, which is, everything, sex is fine, orgasm's fine, but then for hours or days, I have this chronic, deep, aching pelvic pain. So all of those things, you should think there's at least, it's worthwhile to see a pelvic floor physical therapist. The somatic symptoms can be so many. Perineal pain, so they can't sit because they're having pain, or they can't wear clothes because it's irritating that tissue. Exercise tolerance, so especially cyclists cannot tolerate the seat bike. Hip and low back pain, so those pelvic girdle muscles. Leg and foot symptoms can be impacted by the pelvic floor muscles and the structures around. Radicular pain like sciatica or other neuralgias, pelvic organ prolapse, and pressure heaviness.
Yeah, I just want to say, so when you have a patient with all this stuff, they don't want to tell you about their bowel stuff. They're just gonna say, I have this, but look, I had all of these at the same time, and it's just miserable. It makes life really difficult, and I would start talking about it, and people around me like, oh yeah, I have that too. Nobody talks about it. We're all ashamed of these areas, and we don't just show up at pickleball. I'm like, oh, my bowels are messed up, so.
Yeah.
And then you go and see Jandra, and it's like, oh yeah.
Yeah, I mean, even my patients will be like, oh, I know this is TMI. I'm like, this is why you are here. Tell me all about it. I forgot I need to bring my poop emoji pillow back in. That usually starts people chatting. I have this fancy little Etsy Bristol stool chart. So it makes people feel comfortable. If you have to talk about these things, have those items in your office if that comes up regularly, because it sort of invites people to already be like, oh, this is a comfortable place to talk about that. If you have questionnaires, consider adding some of these things as a checklist. Do you experience any of the following? Yes or no? Or, always, sometimes, never. Things like that can generate that conversation. But if your patients have any of these things, they likely have some aspect of pelvic floor dysfunction. It may not be the whole issue, but they will benefit from seeing a pelvic floor PT. So shifting a little bit into kind of the lifespan. This is not an exhaustive list of diagnoses, but just to kind of better understand how it impacts us women throughout the entire lifespan. What's not included here is pediatrics. A lot of pediatric PTs will treat kids with constipation, bedwetting issues that you all may also, if you see kids, speak with about as well. But if we get into adolescents and young adults, you may see incontinence even in those young athletes, gymnasts. I've seen gymnasts that they were really soaking through their underwear and wearing pads at 12 years old because they were competitive gymnasts, and they're 19, 20, and now they're embarrassed because they're having sex, and they might be having incontinence during sex, or it's just gotten worse because there was never actual intervention before. Painful intercourse as we start to date, become, raging hormones and sexually active, you might start to see this here. Endometriosis, if you ask most people who have been diagnosed, it will date back to their adolescence and when their period started or shortly after. Constipation. In children, 8, 9 years old little girls who have not even started their period, when estrogen starts to ramp up, they actually present, oftentimes the first sign is, were you always the kid that went to the school's nurse's office for stomach aches? So as they get breast buds, as they start developing that, even maybe years before they actually have their period, it may be showing its face in the form of IBS symptoms, constipation, tummy aches. So that's something I'll ask my clients too. You know, if I'm suspecting endo, I ask about when they started their period, how it was. We'll talk about IBS symptoms when it started, and yeah, about 8-9 years old. IC, painful bladder syndrome, honestly is oftentimes more often than not a name for symptoms, but not what it's intended. And this is where it gets tricky, because if you're diagnosed with IC, a lot of physicians that comes with its own set of treatments, instillation, Elmeron. And the AUA has updated guidelines throughout the years. I think their last one was in 2022. First-line therapies, pelvic floor PT, diet, lifestyle. But I still have seen many people, first line, let's do some Elmeron, and okay, it's not working yet, let's go higher. Oh, it's still not working, let's go higher. That has some serious side effects. I've had one patient, male patient actually, who lost his eyesight transiently because the Elmeron wasn't working. It wasn't working at 3 pills or 4 pills. I think he got up to 9 pills, still wasn't working, and that happened. But he never had IC. I mean, he had symptoms that gave that name, but that's the problem with naming a diagnosis, is it directs a treatment. Matters less if it doesn't direct the treatment, but that can be very problematic when you're intervening on the wrong structures. So vaginismus we'll get into a bit more too as we go through. Peripartum conditions, dyspareunia as well, especially in that postpartum state. So GSL is a term, genitourinary syndrome of lactation, has been developed. Oh, are we having a fire alarm? This is due to hormonal changes in the postpartum patient. Even if they're not, breastfeeding, chest feeding, pumping, they still go through this period of time where their hormones need to regulate again, and they may have this transient, basically menopause symptom of their vulva, causing both urinary symptoms and painful intercourse. Incontinence, pelvic girdle pain, pelvic organ prolapse, vaginal delivery is the highest risk factor for pelvic organ prolapse. And that comes with embarrassment too, or maybe they're not wanting to be intimate with their partner because they don't like how their body looks, and they feel this weird bulge down there when they're showering, and they have no idea what it is, and they freak out, and next thing they think they have to have a surgery. There's so many more interventions before then, but it's a common thought process, and it's scary. Pelvic venous disorders, which consist of a couple compressive diagnoses, May-Thurner's and Nutcracker syndrome, as well as pelvic congestion syndrome, which might be the term most people are more familiar with if you've heard of, if you're familiar with any of the venous disorders. And then we get into perimenopause and menopause, and lots of the Women's Health Initiative to thank for some of the issues we still have to deal with. But GSM is genitourinary syndrome of menopause. Essentially the same symptoms and vulvar changes as in GSL, it's just a different life stage. We used to just sort of term this GSM for everybody, but I don't think postpartum women love to be kind of in this menopause group of women. So we're starting to change some of the terminology around that to be more accurate, to reflect the life stage. Post-radiation or cancer treatment, of course, younger women can get cancer too and go through these. So again, this is a generalized list. Okay, Tracy told me I have 10 minutes. So I want to introduce this, and you don't have to learn all of this, but I want people to recognize it's there. When you have that complex patient, look at all of the various aspects that there may be pathology, so nociceptive pain coming from a physical problem, right? When somebody comes in with pelvic pain, generalized, everything hurts all the time. I can't have sex. It hurts to pee. I can't poop. You have a structure, a base to go through. So I'm not going to spend time going through these regions, but just so you're familiar, my brain loves this because I'm like, okay, what are all the different pain generators or symptom generators we could be working with? And your role is not to go and investigate all of these, but just know this is here so that when they say I've done everything, okay, have you got, clitoral clitoris looked at, vestibule is a big one, pelvic floor muscles. So there's somewhat of a kind of a flow chart or structure, and many of our patients have multiple of these regions. So it's kind of checking off the list and making sure they're getting, like, all of this has been ruled out. And usually when you show a patient this, maybe they're like, oh, I didn't think about that, or I didn't do that, but they truly have done a lot. My realm is within region 2, the pelvis and the perineum, of overactive and hypertonic muscles. So I'm going to breeze through some of this. What PT looks like, we do a thorough evaluation. So like I mentioned, I'm taking a pretty intensive history. I then kind of generate what I'm thinking I might find, and I look at their tissues we kind of say from knees to rib cage, front and back externally, as well as the vulvar tissues and the pelvic floor muscles. We're looking at, how do things feel? Do we feel a lot of restrictions? Do we reproduce pain on trigger points? That's both internal and external. Are there posture deficits that need to be addressed? Because muscles really respond to the joint position that they're in. So that's an important thing to know, is they may not be weak if we can work on their posture and get everything back to a good baseline. Things might improve, and there's simple fixes to seemingly like long-standing problems. We then look at, I mentioned, I can find stuff on anyone, but does it relate to their symptoms? Sometimes, most of the time, yes, to some degree, and sometimes no. So there may be a lot going on, but I'll say to patients, you do have things we can work on, but I don't know that I will be able to kind of treat these and you have the expected outcomes you're hoping for. I think we need to bring in other team members, do this, come back after X, Y, and Z, and let's reassess if this is maybe involved. And then, of course, our plan of care, goals to address, we think about short-term goals, more like impairment-based, improve blood flow to tissue. That then leads to, better functional control of their bowel or bladder. And then, of course, referrals to the appropriate team members. The question of how treatment goes, there's so many things we can do, but who's driving these symptoms, right? Is the pelvic floor, the musculoskeletal structures, like the main issue despite all of these other conditions going on? Or is it just along for the ride, like I'm being driven this way because you have really bad period cramps because of endo, or I'm like, where is it going and how is it going to respond? And usually after a few visits, we intervene, we try some things and things aren't really changing. That starts to make me think yes, you have pelvic floor dysfunction, but I don't think we're going to get anywhere until this is addressed. So we can perform manual therapy, breath work, exercise, posture work and assessments, neuromuscular reeducation. We can use biofeedback. We educate a lot, and we refer and work with our multidisciplinary team. We collaborate, and a lot of times we are their case manager. So there is so many different things we can do with these patients. I was going to do a little activity, but we're short on time, so I won't do that. But it's not just about Kegels. It's about how you do Kegels, what position you're in when you do them. They're not an end-all, be-all, and they can make people with pelvic pain actually much worse.
Yeah, I thought pelvic floor therapy was going to be doing Kegels, so I avoided it.
Yeah.
And you're like, oh no.
Oh no. Oh no. That being said, contracting your pelvic floor muscles is not a bad thing. It's the repetitive kind of protocol of just squeeze, 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 and you're going to have better sex, and you're not going to pee your pants. So many people fail that, and then they think I don't need it, I've tried that. There's so much more to it. So touch on a little bit of endo here and some of these other diagnoses. So I really liked this quote. Endometriosis suffers from a branding problem. It falls into the abyss of women's diseases, which are overlooked, diseases that don't kill you, unimportant, and menstrual problems, which are taboo. Yeah, so I thought that was a great quote, and I think it accurately reflects endometriosis. So coming up will be some pictures, so if you are queasy around surgical pictures, just trigger warning. So, biggest myth is endo is retrograde menstruation, meaning when you menstruate, there's reflux of menstrual fluid into the abdominal pelvic cavity, which happens to most women. You have 3 holes in the uterus, 2 fallopian tubes and a cervix, right, into the vagina. So pressure, when you get a contraction, naturally will push menstrual debris in every which way. But 90% of women don't have endo. 10%, but I think probably higher than that. But the reason I bring this up is I'm going to show some pictures here. This was Kat. This was Kat, our patient. This was Kat's insides after dismissal. Yeah. Some of this was on, does anyone know what this is? Yeah, right. So, yeah. This is very much not normal. This is the uterus with a very, very big fibroid, likely adenomyosis. This is one of the fallopian tubes. And underlying is a very large endometrioma that completely eradicated any healthy ovary tissue. Wow. I think it was close to 10 centimeters, which is what your vagina dilates to have a baby inside of her pelvis. Yeah. So after years, even trying, does anyone think this could hold a viable fetus? No. And that's a really tough thing because her imaging did show things. And doctors still kind of gave a lot of false hope. And when she came to me, she was seen by this was a endometriosis specialist center. I sent her to someone we work with, and it was like, oh no, you have this, you need this, but nobody gave her those options, which were, basically she just thought she's done everything, right? And she hadn't done everything, but you don't know what you don't know. So here's another example of somebody's inside. So thinking about we don't see this, right? It's inside the body. And so as people look healthy, you never know what's going on inside their body. So this is a bit more of a normal shaped uterus, so you can kind of see and compare. This is another kind of large, about 10 centimeter endometrioma in this patient. These little dots are pretty classic endo symptoms. So most physicians, when they say, oh yeah, I treat endo, they're looking for those little dots. That's one of the most classic lesions. They're not necessarily seeing that line of pulling scar tissue. That will likely be left by a surgeon that says, yeah, I do excision surgery. Those might be removed. That might be removed, likely a hysterectomy, but there's a lot of scar tissue within here that would have never been even touched. This patient, that was underneath near the cervix, and this was a 22-year-old woman who I saw she had a bleeding disorder and started her period. She bled every single day until her surgery. Yeah. She was an ultramarathon runner, couldn't run because she would get severe fecal urgency, almost incontinent, very healthy, 22-year-old. And looked at her diet, sure, she could make changes, but there was nothing that would cause her symptoms that severe. She had surgery. She never had the fecal urgency again. So IBS, right? She was diagnosed with IBS, but it was this hub of multiple types of endometriosis lesions that if that physician hadn't retracted her uterus and looked there, some don't, that would have been missed. And she's, had endosurgery, it was ruled out. This is this is post-excision surgery after a kind of botched surgery. And it's hard when you undergo a surgery with who you think is a specialist. It's not the patient's fault. It's not really the physician's fault either. You don't know what you don't know, but this was sort of the post-excision from a specialist after somebody had kind of gone in and done a lot of ablations or burning of the lesions. So IBS, all of these patients you will see have been diagnosed with IBS, and some of them, their primary diagnosis. This is the sigmoid colon that goes just before it turns into your rectum. See this saran wrappy, filmy thing? That's an adhesion, usually due to inflammation, usually endo, and that's sticking that colon to the pelvic sidewall. So as stool's moving through, it cannot move through until eventually it comes about and things push through, and usually you have this alternating constipation and diarrhea.
Yeah,
Yep.
Can I have it?
Yep.
This is right here to my abdominal wall.
Yeah. This one, this is mine. This is me, right, this picture. But I look healthy, right? But severe constipation. I didn't poop for 3 months at one point and had a colonoscopy. Everything's normal. I didn't have painful periods. So it was really hard to get a diagnosis. When you don't have painful periods, you don't really think about endo. So this was somebody's tissue wrapping all the way around their rectum from their fallopian tube. So you don't see this, right? And you can't even, like when I first started seeing this, I couldn't even imagine to even think about what somebody's insides look like with endo. Summary pain mechanisms. This is a great article. I shared my slides with Tracy, so you can all have these resources. But what I want to emphasize here is I really like the breakdown of how this talks about lesions, so nociceptive pain over time. The endo lesions create a lot of inflammation and inflammatory factors. Those are picked up by the nerves that go up to the brain. But over time, if they're constantly sending signals, right, to the brain that says pain, 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 listen to me, and they're not getting help, not for lack of trying, there's peripheral sensitization in those nerves that happen, along with, over time, more central sensitization. So now you have nociceptive pain, you have peripherally sensitized nerves, and now that turns into or contributes to central sensitization. Can I have 5 more minutes? Can I have 5 more minutes? Okay. So if you watch Sex and the City, Charlotte went to the doctor and was like, guys, my vagina's depressed, right? Because she got prescribed, I think, probably amitriptyline or nortriptyline or something like that. So these meds are off-label use for neuropathic pain. And so what we know about vulvodynia has significantly improved since the 90s for sure, but this is a great example of how social aspects get construed in what we think about these conditions. So in 2003, the ISSVD, the International Society for the Study of Vulvovaginal Disease, basically had vulvodynia as this chronic pain of unknown origin that persists for at least 3 months. There's generalized, there's localized, there's a lot of details around it, but basically there's pain somewhere down there for 3 months and we don't know why. Then the ICD-9, when we look at the changes there, didn't even recognize vulvodynia as a billable code until 2020, and it was still unspecified. So we couldn't even bill for this code before 2020. In 2015, 3 societies came together. ISSWSH, ISSVD, and the International Pelvic Pain Society, IPPS, came together and said, we know a lot more since 2003, so let's better define this to get common language throughout all these different providers and practitioners, so we're all on the same page here. There was a lot more evidence. So they then described vulvar pain in two categories. There's pain caused by a specific disorder. The one I'll talk about more for time is hormonal deficiency. So we have the genitourinary syndrome of menopause, or for a lot of our young women on birth control, hormonally associated vestibulodynia. Vestibule is a part of the vulva, but it's a very specific area. That's going to be largely more of our patients who come in with painful sex, these recurrent non-bacterial UTIs. It's that tissue that really needs hormones and gets inflamed. That's going to make up much of our vulvar patients, which we didn't know about in 2003. So there's now vulvar pain caused by a specific disorder, and then there's still that true vulvodynia of, we really still don't know what's going on. It's more generalized and throughout the vulva, but it's been chronic for 3 months or more. You can look up this paper if you're interested in reading more about it, but there's a few more things I want to highlight. So I will skip this one. But for you all, with this, most women are dismissed by their doctors and given inappropriate medications to treat something. We can help with coordinating that care. We can help physically with helping improve the blood flow around those tissues and identifying and doing a vulvar exam to get them to the right person. OBs aren't really looking so much at the vulva. They go in with the speculum and they're looking at your cervix, your ovaries, your uterus, but they're missing a huge piece in a lot of these cases. So for you all too, asking, about the diagnosis and if they've been on birth control, if it's a 20-year-old, if it's come about during lactation, if they have other signs of perimenopause that might indicate this tissue is at play. This I really wanted to get to, and then I'll stop after this. But this is a paper that is by Hannah Schreier, I think is how you pronounce her name. I have the paper on the next slide, but from the 19th century onward, American judiciaries and legislatures based the validity of marriage on a woman's ability to be frequently and fully vaginally penetrated in sexual intercourse. As a wife was defined by her capacity to be vaginally penetrated, the validity of heterosexual unions came down to the suitability of the genitals for heterosexual penetration. So her paper basically, she's a law PhD in history at Yale, I believe, Yale University. And she really talks about how the medical, legal, and psychological institutions historically reduce womanhood to anatomy and their ability to be penetrated, which reinforces this structural dehumanization of a woman is defined by her body parts and her ability to please a man. Because it came from she does a lot of case history. It's not even just being able to penetrate, it's the level of pleasure of penetration for the man. So this is her paper. There's a QR code. I highly recommend reading it. It's about the history of vaginismus. And it starts out with Marjorie Wentz, who was one of Dr. Kevorkian's patients during his hearing with physician-assisted suicide. She had pain down there and said, at my autopsy, cut me every which way, find what's causing pain. They didn't find anything, right? Because these are invisible. They don't know what they're looking for. But it's a really great paper is not the right word, but important paper to really look at our history. You all will see vaginismus, which is inherently the pelvic floor muscle contractions or spasms, essentially due to nothing, right? But most of this there is a reason. There is true cases of vaginismus, and you usually see issues maybe around trauma, sex, culture, upbringing, our comfortability around sex. But usually my patients who come to me have actually hormone-associated vestibulodynia or endometriosis. There's a trigger for that spasm. The important thing, you'll have my slides here, is with the DSM-5 and how vaginismus and dyspareunia were considered psychiatric diagnoses until 2013. Vaginismus specifically existed in the DSM for 175 years, one of the longest ones with the least amount of change. And so when it did change, it kind of merged into this genitopelvic pain penetration disorder. But that is ridiculous. Especially since 2015, more of the vulvar pain stuff came out in that research, but we did know more before then. So the question is it really vaginismus? It's important to hit the physical markers of that, but also acknowledge that they are struggling and need your help as well. But I think this is an area that is problematic, and it gets...
A picture of that, of what it looks like?
Yes. Where is it?
It's further up. You kind of skipped through.
Oh, yeah. Sorry.
Just because when
yes.
they come in and they tell you they have sexual pain, this is what it looks like.
So this one is really irritated, inflamed redness or erythema. That's due to just it's starving for hormones, basically.
And they call that psychiatric.
Yeah. This is actually, and with treatment, you come back to this nice, healthy pink tissue. But this is missed by so many. I am truly the one who diagnoses this with so many people. So if they're sitting there telling you it hurts to insert, it truly might hurt to insert, right? There's a physical condition that has been missed by most providers. We are working with different groups to help train physicians to do a vulvar exam, a Q-tip test, and a pelvic floor muscle exam so that they can add this to their current pelvic floor or pelvic exam. So I know, sorry, we were short on time. I think that was it. And then I do have a few, just wanted to show when you send them, resources here. If you want to know more about the exam and what it looks like, we did write a paper for physicians, how to find a pelvic floor PT. Here are some resources, and you'll have these slides. And thank you. Yes.
You can look at your exercise and see if anything's changed. And then we'll get Michelle up. And I wanted to make sure we have time for our panel discussion. So we can
Did
get
you
any
say I'm coming up?
Yeah.
Okay.
Oh.
So the next.
Thank you.
I know, there's always so much